So next is, can we identify patients? Because for personalized therapy, you need to understand that we need to have the subset of patients who will derive the most benefit from these therapies. So how do we think about biomarkers for small cell lung cancer? For non-small cell, we really have defined subsets like EGFR mutant patients, they get EGFR targeted therapy. KRAS mutant patients, they get KRAS targeted therapy. But for the longest time, we did not have such subgroups for small cell lung cancer or such biomarkers for small cell lung cancer. And that's because the mutations that we had in small cell lung cancer, they were all loss of function mutations in tumor suppressors such as P53 and RB1. And it was very difficult to have drugs designed for loss of function mutations for these very important tumor suppressor genes like P53 and RB1. And this is just a snapshot of the other important genes that we see. And we also saw amplification of the MYC family members, another of genes that is very hard to design drug against. And other genes where we saw alterations, these are non-recurrent, so only a small percentage of patients have mutations like Notch1 family members, like PIK3CA, KMT2D. So now, when we went beyond these mutations and we looked into the transcriptome and the proteome of small cell lung cancer, what we can see now is small cell lung cancer now transcriptionally can be divided into 4 sort of main subgroups. ACL1 is one of the major transcription factors, and majority of the patients are fall under this ACL1 subgroup. And the next is the NeuroD1. And we also have about 10% of patients that fall under this SPOW2F3 subgroup. And then we have minority of the patients who are more inflamed in nature that have higher expression of immune genes. They also express certain markers, like you see DLL3 being expressed more in the ACL1 subgroup. You see higher expression of c-MYC in the NeuroD1 subgroup. You see higher expression of certain DNA damage response like PARP in the POW2F3 subgroup. And you see mainly immune genes being expressed higher in this inflamed subgroup. There are also targets that we can go after, the most famous being DLL3 for the ACL1, aurora kinase and DNA damage response inhibitors in NeuroD1, PARP in the POW2F3, and then immune checkpoint blockade, mainly in the inflamed subgroups. They usually go from high neuroendocrine to the low neuroendocrine, and mainly from the cold tumor to the hot tumor. When we did a retrospective analysis of the CheckMate 032 data sets, however, we did not see these subtypes actually predicting response to either the PD-1 antibody nivolumab or to the PD-1 plus CTLA-4 nivolumab and ipilimumab. So we did not see these antibodies, these subclasses actually predicting response. But what we did see that the expression of CD8 and MHC1, so the antigen presentation machinery, could actually predict response to either anti-PD-1 or anti-PD-1 with CTLA-4. So potentially, CD8 and MHC expression could be a biomarker for immunotherapy response. One of the problems with having these straightforward biomarkers for small cell lung cancer is that small cell lung cancer is extremely plastic. And what I mean by that is one patient can express multiple transcription factors, or these tumors are highly heterogeneous in nature, which means they can have the flavors of more than one of these transcription factors that I just mentioned. And this was very nicely shown by one of the studies that we published and was led by Natasha Reckman and Marina Bain, is that within the same tumor in one patient, you could see multiple of these transcription factors being sort of expressed. And it shows plasticity, and which is also expedited with therapy. So what small cell lung cancer does is that it is actually a moving target. It can actually change its phenotype, and it can express multiple transcription factor all at the same time, which makes therapy kind of difficult. And also, it also expedites the process of drug resistance in small cell lung cancer. We have seen in the recent studies that we are not done yet. These are not the 4 major subtypes. There are other subtypes that are emerging. Like in the more recent study published in 2024, we are seeing another subtype emerging called the subtype H. And as we will get better in collecting longitudinal samples or looking into these larger data sets and larger multi-omic studies, I think we will see more and more of these subtypes emerging in small cell lung cancer. So in this, how do we come up with biomarkers? How do we select patients? So this is one of the examples of where we have selected a biomarker, we have identified it in the lab and taken it all the way into the clinic. So this is SLFN11, which was identified by 3 groups almost at the same time. This is a DNA-RNA helicase, which predicted response to PARP inhibitor and to chemotherapy, which was later on in a retrospective analysis was also validated in this veliparib PARP inhibitor and temozolomide study, where higher expression of SLFN11 could predict better response to veliparib with temozolomide. Based on that, there was this SWOG-sponsored S1929 study that was done that actually selected patients based on SLFN11 positive, and they were randomized into receive atezolizumab which is an anti-PD-L1 inhibitor, or in combination with talazoparib, which is a PARP inhibitor, talazoparib. So this study showed a marginal benefit in the progression-free survival, where the patients who were SLFN positive had a marginal benefit in the progression-free survival with atezolizumab and talazoparib. However, this was negative when it came to overall survival. But I think the importance of this study is that this showed sort of the feasibility of doing biomarker-driven study in small cell lung cancer. And based on that, I think we are seeing a shift. We are seeing a shift not just in the treatment landscape, but we are also seeing a shift in doing biomarker-based studies in small cell lung cancer. So we have gone from a black box into dividing patients in small cell lung cancer based on subgroups. And now we are actually trying to do trials based on biomarkers in small cell lung cancer. And this is just one of the examples. This is also a SWOG-sponsored study, S2409, PRISM study, where patients are being selected based on either SLFN positive or negative, and also their subtypes, A or N subtype, and then inflamed subtype, and they are either receiving durvalumab or combined with a PARP inhibitor or a ATR inhibitor or with an NK targeted therapy. So we still have to see sort of the results from this study, but this is the first time we are seeing biomarker-driven studies being attempted in small cell lung cancer. So what about biomarkers for the T-cell engagers that I was talking about? I think we are still not there yet. I think the jury is still out, because from the data that we have seen from the Delphi 300 study and from Delphi 301, we could not see a clear correlation of DLL3 expression and the patients who actually derived benefit from tarlatamab. But a caveat was that DLL3 status was not mandatory in these studies, and these results are based on a subset of patients where tissue was available for analysis. So I think we need larger data sets where we can see whether DLL3 could be a biomarker for these DLL3 targeted T-cell engagers. I talked about antibody-drug conjugates, and this is just one of the data that I'm showing where in this B7H3 targeted ADCs, we did not see a significant correlation between B7H3 expression and the patients who actually derived benefit from this B7H3 targeted agent. But again, we need larger studies, we need more prospective selections, and I think, again, the jury is still out there whether the surface expression of these markers would actually predict response, or whether we need better ways to actually estimate whether IHC is a good way to estimate these expression, or we need better platforms to actually look at the expression of these biomarkers. And thinking about that, I think there's a very nice future for liquid biopsy in small cell lung cancer, where we can not just look at longitudinal profiling of these tumors, but we can use these platforms like DNA methylation and fragmentomics, and also other platforms that are emerging to look for the expression of some of these biomarkers. So the take-home messages and next steps for small cell biomarkers and subtypes: there are these new wave of agents that are active in this recurrent metastatic small cell, including T-cell engagers and ADCs. We are seeing a lot of movement in the clinical setting, but I think investment needs to be done in preclinical studies to identify biomarkers and response. And we don't understand anything about resistance, and I think we need to invest in that. Small cell subtypes, they are actually cell states rather than fixed lineages, and we need to treat it like that, and we need to understand whether they can be used to define therapies in the clinical setting. And of course, there are clinical trials ongoing. I think we need to understand whether we need multiple biomarkers and when do we actually assess. So biomarkers in the relapse setting, we need further validation for that, and whether liquid biopsy could show promise in predicting these biomarkers, whether it could be predictive and prognostic biomarkers, and can cfDNA capture these? When should we test? And based on this, based on what we see, can we switch therapy? And what would be the optimal timing of actually doing these testing? Should it be upfront? Should it be on relapse? And should we keep doing the longitudinal? And based on the changes that we see, are we there yet in switching therapy? So these are all open questions, and I think we and others are actively trying to answer this in the lab. So based on that, I would like to thank my team, my collaborators, of course, funding agencies, and definitely the patients and their families who are very generous with the knowledge, with the samples, and none of this would have been possible without very generous collaboration with the patients and their families. And of course, my institution, The Ohio State University. Thank you very much for being with me in this session. I would just like to end by saying this is a very exciting time for small cell lung cancer research and treatment. I think we are seeing a shift in the needle after decades. We just have to keep going in terms of research and treatment. Thank you all.